Thank you, Dr. Ankumar, for that very generous introduction. I'd like to congratulate APDF for continuously raising the bar. Every time I've come to APDF, I find that it gets better, bigger, and more prestigious. So it's a great honor for me to be here today. It's also nice to see so many of my students. I'd like to congratulate Dr. Vijay, the scientific committee, for organizing this and for remembering me and to invite me for this talk. My talk is made very easy because I think Dr. Vagesh Iyer's and my talks are almost exactly the same. I didn't realize he's talking the same topic, but anyway, it doesn't matter because I counted the number of slides and not too many slides overlap between our two talks. But I am only going to emphasize what he said, that there is some place for early and aggressive treatment of type 2 diabetes, particularly at the time of the onset or the diagnosis of the disease, which might help in reversing the natural history of diabetes. So that's the concept which I'm going to talk about. This slide he already showed you, and therefore I'm not going to talk about it, except to tell you that while the insulin resistance rises and then kind of levels off at some time or might keep increasing, there's definitely a loss in beta cell function. This loss of beta cell function actually pushes one from the stage of normal glucose tolerance to pre-diabetes and to diabetes. So we should always remember the beta cell when you're treating patients, because there are agents which can worsen the beta cell function and there are agents, hopefully, which can improve the beta cell function. We should try to keep that in mind when we treat. I'm going to pause for a minute and talk to you about assessment of the beta cell itself, because this is something which is very rarely talked about in meetings. You can do this in two ways. One, you can look at the static studies, which means, and this is the most commonly done thing in clinical practice because you don't need any stimulation. You just take a sample and then look at beta cell function. You can do this by way of a fasting C-peptide, which I'm sure many of you do, fasting insulin, and also by measuring the HOMA beta. This can again be measured from the fasting insulin and the fasting glucose by the formula which is given there. But more importantly, there are dynamic studies, and dynamic studies are actually more important because they're more physiological. So if you stimulate the beta cell in some way and then look at what happens to the beta cell, and you can do that, the simplest which we actually described about 30 years ago, I think 35 years ago when I was at DRC, we described this test, a simple postprandial challenge. In fact, we even zeroed in on the 90-minute, after doing numerous studies, a 90-minute postprandial sample as being a simple, and I have almost 80 or 90 papers published using that. I was very pleasantly surprised when about 3 months ago in Diabetes Care, there was a paper saying that you can use a 90-minute C-peptide after a breakfast as a new test being described, because we described it about 35 years ago. And we've been using it consistently even now. And most papers accept it. Even the 90-minute thing, many people don't accept. It's 120 minutes, as you know. But that particular paper in Diabetes Care talks about 90 minutes for some strange reason. So that's something which we have used. Glucagon can be used. It's a 6-minute test, produces nausea. It's not that good. And so we prefer the meal test because you can do it in the daily practice. You can use what is called as disposition index, and I'm going to talk about that in little detail. In disposition index, what you do is you look at the acute insulin response. So you give glucose, and 30 minutes after that, like we do in the old GTT, take a sample for glucose, take a sample for insulin, and using this formula, you can calculate disposition index. To my mind, this is one of the simplest tests in practice as well as for research to assess this, and I'll talk about that. And of course, more recently, we've been doing the frequently sampled intravenous glucose tolerance test. My colleague, Dr. Gaurav Basal, I don't know if he's here, he has been working on this, and we've already done about 20 or 30 of these, and next month, we're actually starting our CLAMP studies. So these are for more advanced research studies to answer some more definite questions that we are trying to answer the Asian Indian phenotype and the fat studies and so on, which Dr. Vagesh talked about. I won't talk about that, but I'll talk about the disposition index. So my first concept that I want to talk to you about is beta cell function in early diabetes. And this is put in inverted commas because I think in a way Dr. Vagesh alluded to this using Peter Butler's data, but this is DeFrance's data where he is showing that if you look at the disposition index, which is the measurement of the beta cell function, in people who have normal glucose tolerance, IGT, and diabetes. And normal glucose tolerance is this value here, 2-hour value up to 140. 140 to 200 is IGT, and then beyond that is diabetes. And the reason I show this in almost all my talks now is that we tend to underplay type 2 diabetes, and if somebody has a 2-hour value of 210 or 220, we almost kind of dismiss it and say, you just got little diabetes, don't worry about it, and so on. What we tend to forget that if you look at the whole picture, if you look at the whole natural history of diabetes, this person has already lost quite a bit of beta cell function. By the time they reach the stage of this type 2 diabetes that we diagnose, almost 80% of the beta cell function is lost. What is more revealing from DeFranzo's work, which actually opened our eyes, is that even by the stage just entering the IGT stage, about 140 milligrams 2-hour value, if it was 135, we'll even call it normal. By that time, 50% of the beta cell function seems to be lost. So this seems to be a slow, progressive, but inexorable progression to beta cell dysfunction, which is occurring in people. And it's very important to keep this in mind. We then started very large studies, and this paper was published in Diabetes Care a couple of months ago. It's a very large study. We looked at almost 20,000 people in Chennai, where we screened people. We took out people with diabetes, first of all, so we didn't want them, they'll be on various treatments, and we didn't want that to bias this data. So we took out people who knew that they had diabetes, and then those who said they did not have diabetes, about 20,000 people. We did OGTTs, we did disposition index, we did insulin assays on them, and then we calculated the disposition index. Now shown here are the details, which is published in Diabetes Care. So this is the disposition index in normal people with normal glucose tolerance. It doesn't mean that none of those will progress. There is a subset there also who will progress, but I'm not going to talk about that. Then we found people, when we screened, who had just impaired fasting glucose, or IFG. We had a group who had IGT but did not have IFG. Then we had a group who had both IFG and IGT but did not have diabetes. Then finally we had screen positive diabetics. So people who said they were normal, but when we did the GGT, we picked up the diabetes. When you looked at the disposition index shown in blue, you can see that by the time they've just entered the stage of IFG or IGT, considerable amount of beta cell function is lost, exactly like what DeFranzo showed. Now this is very important because his population was a totally different population. It was a very obese population with a BMI around 28 or 30. Our BMIs were like 23, 24. So even at this BMI, there seems to be in our population a considerable loss of beta cell function, which is actually increased further if you have obesity, because obesity has its own effects on the beta cell function. What was very surprising was that if you had combined IGT and IFG, you have not even entered the stage of diabetes, more than 60% of the beta cell function seems to be lost. And of course, these people who didn't even know they had diabetes, and we went to their homes and we picked them up, 80% of the beta cell function was lost. So we were able to confirm what DeFranzo did in a different population with a completely different phenotype, but this seems to be true. So we all the while, in 1985, the first paper on raised insulin levels in Indians and the first clamp studies in Asian Indians was my work, which I worked in the UK and proved that. So all these years we've been biased just thinking that Asian Indian phenotype just means insulin resistance. We now have data that beta cell function is also very, very important, and therefore when you treat patients, you have to keep both these in mind, both these defects, both the beta cell function as well as the insulin resistance. Now the question is this a permanent beta cell function loss? In other words, the structural damage which Usha also talked about and Dr. Vagishair also talked about, or is it reversible? In other words, this 80% gone, is it gone forever, or is there any way by which you can revert it back? What I would like to call a stunning of the beta cell. If there is a bee flying here and you just tap that bee like that, the bee will go and fall there and you will think it's dead. But after 10-15 minutes, the bee will fly because it is only temporarily stunned. So is that beta cell just undergoing a stunning, or has complete apoptosis occurred whereby all the cells are dead and nothing can be done? So we have to do this by clinical studies, and I'll show this to you later. Just a minute to digress on this. Why tight control of diabetes at all from the beginning? Why this early and aggressive treatment? Why can't you take, because mention was made of other studies, too tight glycemic control is not good. Accord showed us that and so on. But that's a different population, much older population. People had cardiovascular disease who are very high risk, already had a heart attack. We're not talking about that. We're talking about the common garden, young patient, low risk, highly diabetic, diagnosed at the time of diagnosis. What are you going to do about that? Now we know this magic value of 7%, which everybody accepts, and we want to keep our patients at 7%. But what happens is, again, I think we are partly to be blamed, because what we do is we tell our patients to reach 7%, oh great, we tap them on the back, and we've often found that when you do that, they don't come back. They think they've achieved it forever. That's it. For next 10 years, nothing happens. Nothing can be further than the truth, because the very next month the control will go out of the diabetes control will go, and it will be 3 years later, 5 years later, and come, you only told me that I did very well. Or maybe I shouldn't have told you that, Maybe I shouldn't have told you at all. Because what happens is that if you don't see them, the HbA1c begins to rise, and the longer you wait, the longer this glycemic burden, this area under the curve of the glycemic burden keeps on increasing. What would have happened if you called them a little earlier? What would have happened is that this person would have probably come back there, this is in months, and then you had another chance to bring it down. So this is what is called as the unavoidable glycemic burden in green, and in red is the avoidable glycemic burden. At least that much you could have avoided, okay? What if they came back still earlier? Then the unavoidable burden goes down like that, and like that. So if you keep seeing your patients often, so that's the second message I'd like to try to give you now, is that even if your patients are under good control, kindly insist that they keep coming back to you. It's like a good student hitting 100%. There's no guarantee that this person, unless he keeps on trying, will maintain that 100%. If you relax, then they're going to drop. So that's another message that I'd like to give you, okay? This is at an individual level. How does this go at a country level, okay? For example, if all our diabetics were uncontrolled, what is going to look up the study called as the ICMR INDIAB study, or the India Diabetes study, with a total sample size of 124,000 people, representing the 1.2 billion people of India, all the 28 states and 3 union territories, and they gave MDRF the chance to do this study with collaborators from every state of the country. We have the first phase, we completed 4 states, Tamil Nadu in the south, Maharashtra in the west, Jharkhand in the east, and Chandigarh in the north. Then we went to the northeast, where we have about 6 states have been completed, and the last 2 states will be complete in the next 3 to 4 months. It's the first time in India's history that the northeast of India has been studied for anything. People don't even go there. It's very difficult to even get there. I've been personally going to each of these states, to Mizoram, to Arunachal Pradesh, to Manipur, to Sikkim, and so on, to go and actually see there the conditions there. It's like a different world altogether. Some of those places you cannot even reach. There's no roads there. You have to take helicopter to go there and so on. That's how we're doing the study. But it's a very great challenge, but I'm glad the northeast is being studied. Then we started the rest of India, and we've already completed now Gujarat, Karnataka, Andhra Pradesh, Bihar, and Punjab, and we are starting off in the other states. About 50% is over. So 14 states of India, about 700 million people have already, that's 3 times, 2.5 times US population, has already been studied, and it's already become the largest study ever done in the world. When we finished the first phase, we looked at the number of people with diabetes in India, and it turned out that we had 62.4 million people with diabetes in India and 77 million people with pre-diabetes in India. And what is relevant to this talk is this one. So we also looked at in Chennai, in the CURE study, as well as in the Chunampet and the surrounding areas in rural Tamil Nadu, the complications rate, retinopathy, nephropathy, neuropathy, as well as coronary artery disease and peripheral vascular disease in urban Chennai, as well as in rural Tamil Nadu. So based on these, we got the urban-rural complications for the first time in this country. I think these are only studies been done on a population basis. And from here, we extrapolated to the number of people who might have complications in India. Turned out that almost 17 million people, for example, have diabetic kidney disease. And we know from Dr. M.K. Mani's work and other nephrologists who have been working on it, that only about 2% of people with end-stage renal disease in India can afford either dialysis or transplantation. 98% of people cannot afford to have either transplantation or dialysis, and therefore they will die. Okay? So the only thing you can do is to prevent it. And we heard from the talk from Usha Sriram and others who spoke before me that the metabolic memory leads to these complications, and it's only tight control of diabetes which can prevent it. The good news is that this is again the first paper in the world, to my knowledge, the only paper in the world published so far, on long-term survivors with type 2 diabetes. There are 2 papers in the world on type 1. One from Joslin Clinic and one from the UK, which has looked at people with type 1 diabetes, children with type 1 diabetes who have survived 50 years or more. This is a paper on type 2 diabetes patients who have lived 50 years or more, and this is published in Diabetes Care again a couple of months ago. And what we reported there was that if you read the last line, nothing very great, but it's just that it's the first report in the world, that long-term survivors with type 2 diabetes had better glycemic control, better blood pressure control, and more favorable lipid profile, including use of statins. And we had a comparative group of non-survivors as well, those who died after 10, 20, 30 years and so on. The other good news is that all these type 2 patients who survived were treated with simple sulfonylurea and metformin. What did we have 50 years ago? We didn't have anything. Almost 30, 40 years of their life, they had no other drug except metformin or penformin those days and sulfonylurea. Some of them took insulin. All the other drugs came in the last 10 years. When these patients were only in the last 10 years of their life, they were treated with that. So we didn't have all the complicated, expensive drugs, which have a lot of side effects, which made these people survive. So with very simple, cheap treatment, these people were able to live their lives. The last part of my talk is exactly what Dr. Vagesh Iyer is trying to show you, but in a slightly different clinical perspective. Can beta cell dysfunction be reversed by early insulin therapy? All of us use insulin as a last resort. Okay? So once all the complications come and you tell your patient you've got eye complications, you can go blind, or your kidney is already affected, then they'll ask you, how many times should I take insulin? They're not going to ask you, should I take insulin? Okay? They're all ready at that time. Or when everything is exhausted, we saw the ominous octet. So you give 8 drugs for diabetes now. Every single drug that is available in the market, all of them fail, and the HbA1c keeps on rising. At some point, your patient will say, okay, now put me on insulin. Okay? That also we know. But the case we're making now is a slightly different paradigm. Can you use insulin at the time of diagnosis of diabetes? In other words, asking the question, is there any benefit in initiating intensive insulin therapy at the time of diagnosis of type 2 diabetes? Now, this was already shown by Dr. Vagesh Iyer, the Weng et al. Study. I'm not showing the smaller studies, Ilkova study and so on. The Weng et al. Study is the best study because it's the largest study, number one. Number two, it's a randomized clinical trial. It has over 100 people in each arm, and he showed one part of that study. I'll show you another part, that if you look at the groups who were newly diagnosed with type 2 diabetes, randomized into those who received the pump, those who received multiple insulin daily therapy, and then oral drugs. And the oral drugs used were a combination of glycoside and metformin. So 2 drugs were used, okay, not even 1 drug. At the end of 4 to 6 weeks or 2 months, what they found was that the changes in A1C were not that different, although there were some differences. The big differences came, if you look at the last part of the slide, with respect to the insulin levels. This is the acute insulin response, what I was talking about, the disposition index. And if you look at the values of insulin in the 3 arms, at the end of that 4 weeks or 8 weeks of treatment, there was not a significant difference there, slight differences. The big difference was found at the end of 1 year. So those who had received the insulin pump treatment or had received multiple daily doses of insulin seemed to preserve their beta cell function even at the end of 1 year. But look at what happened here. More than 50% of the beta cell function has gone in this group. They seem to have responded well. But 50% of beta cell function seem to have gone because of something happening which if you give only the oral drugs at the time of diagnosis, it doesn't seem to work. Whether it's due to sulfonylureas or due to something else, we don't know. I'll just show you a couple of cases. Therefore, we have now started a new paradigm of if patients have uncontrolled diabetes at the time of onset of type 2 diabetes, we use insulin. Okay, and I'll show you just a couple of cases. This is a 53-year-old male, 8 months duration of diabetes, central obesity, treated with 1 drug when he came to me, glycoside 80 milligrams twice a day. Blood sugars 217, 344, A1C 11.4. So what we did was, we said, for every agent that we're going to use, maybe we'll get a 1% reduction in A1C. So we said, let's add sitagliptin to this because of the claimed benefits on beta cell function. We added metformin because we said otherwise something for insulin resistance, glycoside. After 4 weeks, insulin was stopped. The A1C came down to 7.1. And what we found was that the fasting C-peptide improved from 0.9 to 1.4. And the stimulated C-peptide almost made a complete recovery like a person with normal glucose tolerance. So here is a patient who we thought the beta cells had gone, which had completely changed. So I'm now introducing this concept of functional recovery of beta cells or recovery from the beta cell stunning which has happened. Here is another story of 2 brothers, a doctor who came to us and his brother. The doctor came to one of our clinics where we gave them this insulin to start with, and you can see from a HbA1c of 11, It has come to 5.4 and 5.5. These are not A1C values which we are used to seeing in practice, because we normally just give them 1 drug, 2 drugs, we get 7% and we think we're very happy. But you can bring it down to 5.5%, okay? Look at the recovery of beta cells in this particular individual. His brother, I'm just done in another minute, my last 2 slides. So his brother was treated without insulin, A1C came down to 7.9, and this 5% reduction in A1C, we are very happy, okay? Fantastic improvement. But it's not reached 7% even at the time of diagnosis. And look at his beta cell function, only a slight improvement in beta cell function. The one who received insulin seemed to recover almost completely and dramatically. Question you'll ask is this temporary, or can you have it for a long period? I don't have follow-up data, but here is the data, again published in Diabetes Care late last year, which shows that up to 3.5 years, this beta cell function can be preserved if you give them just 2 to 3 months of initial insulin therapy. After that, no insulin. 3.5 years later, they're doing well, okay? And this is the meta-analysis and systematic review which Dr. Vagesh Iyer showed, which put all the slides together, and Lancet concludes that there is a definite role for early and aggressive insulin treatment. So I'd like to conclude, ladies and gentlemen, by saying that effective treatment of type 2 diabetes requires multiple drugs used in combination to correct multiple pathophysiological defects. Treatment should be based on the known pathogenic abnormalities which should be addressed, and not just aim at reducing A1C levels. You should consider a short course of insulin in all newly diagnosed patients, type 2 patients with A1C more than 8.5. Even 1 to 2 months of insulin therapy can work wonders, as improvement in both beta cell function and insulin resistance occurs. There's a lot of data for this, I've not shown you this. And this new paradigm may help, at least in part, in reversing the natural history of type 2 diabetes. Thank you.
Sir, regarding that type 2 diabetes and insulin therapy, you are telling about the doctor brothers. You follow any time specificity? Because as soon as you diagnose, it's better to go for insulin or any particular time, because to preserve the beta cell for replication.
Yeah, I think it makes most sense to do that at the time of diagnosis of diabetes, because that is a time when you have glucotoxicity, you have lipotoxicity, the beta cells are not responding, so that initial 3 months, and found the prolonged effects up to 3.5 years. So we have now got follow-up for about a year, year and a half, and they seem to be doing very well. So it makes sense to do it at the time of diagnosis of diabetes. Very often you can get away with just one injection. One long-acting insulin, or degludec is going to come, we have got Lantus, so one of those should be sufficient. But if the sugars are really high, the fasting is really high, and the postprandial is also high, I use 2 insulins, one in the morning and one in the night. That has been sufficient in all the cases that I've used so far. I have not used more than 2 injections at the time of diagnosis. After the first week or 10 days, the morning insulin can be withdrawn, and then the evening can be continued. And after another couple of weeks, that can also be withdrawn, and by the time the sugars are really normal, you'll begin to see blood sugars which you've never seen. Find 75, 80 fasting, 110, 120 postprandial, these kind of blood sugars which we normally don't get in a very severe diabetic when they come to us. When it comes down from 300 to 200 or 180 or 170, we are very happy. Remember that this is the only chance you have after the diagnosis to bring it down to such low levels. Later on, after another 2, 3 years or 4 years, you may not get this 5.5 and 5.4. Only in this beginning stage, that's the best that they're going to get in their life. If you achieve it then, later on the A1C may increase to 6 or 6.2 and 6.5, and it's still very good. It may take a few more years for it to reach to 7%. If you only bring it down to 7, 7.5 in the beginning itself, you have not even achieved in the initial stages. When are you going to, after 5 years, 10 years, how are you going to achieve that 7%? So that is why get the best blood sugars possible for that individual at that given point of time. I'm not saying everybody should come to 5.5, but if it is possible and the patient didn't have hypo and they're comfortable, why not? Then you're almost bringing them to the normal level.
Any cutoff points, sir? Any cutoff points for starting?
A1C? We normally use 8.5. So if the HbA1c is more than 8.5, and the reason I do that, I didn't show 2 of the slides because anyway I've overshot my time. In the Origin study, for example, where the A1C was almost normal, and they included pre-diabetic individual, people who are just diagnosed, who had 7 HbA1c, their giving insulin didn't make any difference at all, either in the prevention of diabetes itself or in prevention of cardiovascular disease. So we started too early, it probably doesn't serve its purpose. The other thing is that then why not continue insulin forever if it is so good? UKPDS showed that that also didn't help. UKPDS is exactly what they did. They gave one group insulin, one group oral drugs and metformin and sulfonylurea and so on, and it didn't make any difference. Only the A1C which made a difference. So continuing it for lifelong from the beginning in a type 2 diabetic who has insulin resistance may not make sense. Okay, but in the initial period, just to correct that and to reverse it is the place. It seems to have its place there.
Thank you, sir.
Sorry.
After a few weeks of insulin therapy, once the sugars have come down to normal, then how to proceed? Then you have to go to OHS?
We start the oral drugs. I'd like Dr. Vagisha also to respond to this, but we start the oral drugs along with the insulin. It's not that first we give only insulin and don't give. That doesn't seem to work, because what you're doing is you're not stimulating the beta cells, you're not correcting the insulin resistance, and you're just adding on insulin when the insulin, then there might be hyperinsulinemia, there may be insulin resistance. So we add the insulin along with the oral drugs, then we take off the insulin. Slowly one more of the oral drugs may be stopped. As he showed, there are many cases who go into complete remission. At the end of a year, they are not on any drug at all. Of course, it will come back. We are not cured the diabetes, we are not done bariatric surgery, we are not done islet cell transplantation. I'm not saying that it will go away forever. But that improvement that you get is going to have a long last. Suppose for 6 months, 1 year, you have the effect. That continues for a very much longer period. Plus, you've improved the beta cell function. So you're ending up with a person who is now having a better beta cell function. Yeah.
After OHS,
Yeah.
they become normal within 1 month.
Yes.
And they will be like that for fewer months. After that, they will stop the medicines. But
If you are able to do that with the oral drugs and achieve it, that's fine. But the Weng et al. Randomized clinical trial, which was done in a randomized clinical trial fashion, showed that the oral drugs alone were not able to do that. So in a given individual, if you feel that it doesn't warrant insulin, but you can still achieve it by 2 or 3 drugs and able to achieve it with oral drugs, that's fine. I was only saying that there is a role for using insulin in patients who have uncontrolled diet. Suppose they come to you with HbA1c of 11, for example, or 10%. At that time, giving just 2 drugs and 3 drugs, oral drugs, if you give insulin for some time, it definitely seems to have a role. I'm not saying every single patient should be put on insulin. I'm not all saying that. It has to be individualized. It has to be, the patient has to be willing for it. You have so many other factors are there. But there is a role for it. Consider it. That's the only point.
Sir, to Dr. Mohan. So what I understand is that a newly detected type 2 diabetes, cutoff level should be about 8.5 onwards. You recommend simultaneous starting of insulin, that's probably a basal insulin, along with OHA. Do you have some criteria when we can withdraw this insulin, like the HbA1c or some guidelines where I can,
yeah.
and how long should I proceed with it?
Yeah. I don't think we have all the answers, but from the 1 or 2 of the studies which I showed, I withdrew the insulin even before the A1C became normal, because it has already started doing the job and the A1C started coming down. So even when it was around from 11 to somewhere around 7.58, at that time itself I withdrew the insulin, because if you continue it, then the chance of hypoglycemia is much more. And remember that the tablets are also working. Now the glucotoxicity is gone, so now the tablets take over. It's not the tablets don't have any job. They are also fantastic. But they need, when there is acute glucotoxicity and lipotoxicity, the tablets will be struggling. That's a time when that little help. It's like a man who has had a fracture. You tell him to use crutches for some time. It doesn't mean that whole life he's going to use crutches. But if he doesn't use the crutches the first 2 weeks, he may fall and have another fracture. Okay? So the crutches are only a temporary thing. Or a car which doesn't start. You give it a little push and then the car starts. So like that, it's only the little push that we are giving. And it's left to you and to the patient and the individual patient to decide when to stop and when to continue and so on. We use sulfonylurea, yes. Certainly we use sulfonylurea, yes. It doesn't matter, because the glucotoxicity is being corrected. The other point that when you use sulfonylureas, use smaller doses of sulfonylureas. Don't keep on driving. That's the other thing that we do. When we start very high, when you see very high blood sugars, we also use very high dose of sulfonylurea, saying that the smaller dose won't be sufficient. Instead of that, start with a smaller dose of sulfonylurea, use the insulin to counter the glucotoxicity, and then use small dose of sulfonylurea with metformin. That works. And if they can afford DPP-4 inhibitors, then that's fine. I mean, the gliptins are great. I mean, they do have some effect on beta cell function. They're weight neutral. They do have remember the cost factor, number one. Number two is that when you have acute leukotoxicity, I don't think the DPP-4 inhibitors can do that, or even the GLP-1 analogs. At that particular time, insulin seems to be the best. Exactly. Yeah. So questions to other two speakers? Can I ask Arvind something? I mean, I loved your talk, but I do have some different views on that. See, you said that at 6 years, the long-term follow-up, 62% had remission and 38% developed diabetes. So it shows it's not effective. I would argue that there is no therapy in diabetes today. There is no therapy in diabetes today, whatever you do, which produces 62% remission. Even islet cell transplantation has not done it. Pancreas transplantation has not done it. So if you can get 62% of people in a complete remission at the end of 6 years, imagine another 10 to 15 years, the metabolic memory will be there. So if the side effects are not, and we've had only one report of colorectal cancer, and all of you are willing to accept the pioglitazone bladder cancer story. So if after 10, 15 years, there is a small risk of colorectal cancer in people who otherwise died. These people are 180 kilograms and 140 kilograms in weight, who may not have lived 6 years. They may have died before that, And these are people at the end of 6 years, they're in remission. That 6-year remission will probably give you another 10 years of metabolic memory. So what if the lipids didn't come down? Give them a statin. Well, who's preventing you from giving statin to them? Give statin anyway, to them. So if the diabetes remission occurs, little drop of blood pressure occurs, with the statin, if you can get the lipids under control, I would argue it's a fantastic treatment.
So I absolutely fully agree with you. That's why if there are comorbid conditions, at the end of 6 years, if the diabetes is under control, it's a very great thing for that patient. So the risk benefit has to be measured in each individual. So it is his healthcare team which takes a decision. Can he afford it? Can we actually follow up this patient? Can we really go ahead and do it? And those who benefit are absolutely grateful to the bariatric surgery.
Dr. Arvind, I have Dr. Arvind, I have a question.
I know you guys are waiting to pounce on me. Yes.
Not really.
I know.
This was some data from Brazil, and I happened to listen to the gentleman. What about surgery in normal weight individuals for reversal of diabetes? What is the benefit? There are some reports, but I don't recollect. So if anybody could...
Well, normal weight has been highly questioned. I did not go through any of the data in normal individuals who did not have diabetes, but why did they do bariatric surgery?
No. They did the surgery in brittle diabetes patients. They have data on pump with very good data using insulin clamp techniques to show remission.
If I'm right, I don't remember the study, but the numbers were very, very small.
Yeah, it was 35.
Can I answer that? Yeah. So they have done in type 1 diabetes. So your question is, in type 1 diabetes, there is no beta cell function at all. Does it work? There have at least 3 studies which have shown substantial lowering of A1C in people who never got their diabetes under control, even with pump. Massive weight loss, because even there are huge guys with type 1 diabetes in the West, as you know, just like type 2. Their weight reduction occurred, quality of life improved, A1C improved. So even in type 1, it improves. But overall, if you look at type 2 patients, if those who have good C-peptide seem to do much better. So your thing about the shorter duration people doing better, especially for remission. So if they have good C-peptide, the remission rates are certainly higher. If it's a long drawn out, 20 years uncontrolled diabetes, very poor C-peptide, they'll still do well. I mean, the insulin requirement will come down, number of injections will come down, but to expect remission there is a bit far-fetched. That you may not get. Dr. Shnesha.
Yeah, I think Arvind's had a fight with his surgeons because, or maybe they didn't. You lost a game of golf. I don't know. The question is, there is a lot of data that is accumulating about, and Dr. Mohan was right. I mean, very rightfully pointed out, that 60% is something that no therapy achieves. But the one common theme, and I hope that theme comes out because the 3 of you are together, is that whatever we do in diabetes has a therapeutic window, and that window is 5 years. That's right. Now, Vagish, I wanted you to sort of elaborate on this. It seems to be that people talk about GLP-1s working and reversing beta cell function, but none of this works after a few years. There's a lot of data that supports it works this thing. The issue is whether you do bariatric surgery or early insulin, Or if you take this new John Hughes article that talks about combining degludec and GLP-1 analogs, they have achieved A1Cs of 5.5, 5.4 in their data. I'd like you all three to comment about the importance of this therapeutic window, because I think that's really the crux of diabetes. You wait, you lose the game. Each one's comments, please, because it's really important.
Yeah, I think what is important is at the time of diagnosis, you have got at least 50% of beta cells are preserved. When it reaches 80%, no way you are going. Same thing in a type 1. When they are 80% lost, they require insulin. That's why you are diagnosing. At diagnosis, you have got a huge mass. That is 50% of the mass is available. So you can preserve it and you can control, and also you can have a metabolic memory for a longer duration. That's why all initial, whether it's a bariatric surgery, intensive control at the initial diagnosis, or a good metabolic control from the beginning, you have even a GLP, everything works best from the beginning, because you have got a bigger mass of a beta cell to preserve, so that, and it is as a natural course. We know that there is 1% of general population turns out to be a diabetic every year, 0.7% to be precise, whereas when it comes to the IGT, it is 10 times, it is around 10%. So you have got a good beta cell mass, you are preserving it for from the beginning for a longer duration, so also your metabolic benefits.
I think I entirely agree, and I think the point is very well taken. That is the whole message that I was trying to say, that early and aggressive treatment. Because what we say as early, the thumb rule is that already you have lost 5 years. Before your average type 2 patient comes to you, at the time of diagnosis, already 5 years would have gone. So thumb rule, it may be 1 year, maybe 8 years, maybe 10 years, but average is 5 years. When they've already lost 5 years, don't think it's very early. You've already lost 5 years. So the first few years are most important. UKPDS told us that, DCCT showed us that, EDIC showed us that, everything showed us that the first few years are very important. And therefore, if you can induce remission then and hit hard at that time, and that's a time when they're younger, they don't have so many comorbidities, they probably don't have heart disease at that time, and therefore, if you're talking about somebody who's 70 years old and had a heart attack and then diagnosed with diabetes, I'm not saying push hard then, and what are you going to do? After 120 years, he's going to be without complications. So you're not going to do that. I'm talking about our patients who normally come at 30, 40, 25, 30 years. They have a long way to go. They must enter that long-term survivor list which I showed you. Because if you want to achieve that, you better get good control from the beginning and keep at it for many years. And if you can get the first 10 years gone, next 20 years you don't have to worry about it. Whereas you miss the first 10 years, you miss the bus. You can do what you want after that. They will develop complications.
Dr. Mohan,
Krishna wanted to...
Again,
we'll just finish off Krishna, then we'll take the next year.
I have one more question. This is directed again to Dr. Mohan and Vagish. I love your stunning this thing. The question is, there's data accumulated, and I want your comment on this, that are we looking at a hibernating beta cell like a hibernating myocardium in heart disease, and at the right time there is some data that says that insulin cells become glucagon cells. Is insulin actually converting these glucagon cells back to insulin?
It could be. There is some very exciting work from Ferranini and others exactly using the same word, the hibernating beta cell. And they're showing, these are animal studies of course, where in animal studies they're showing that it's actually hibernating. And there again, in the animal studies they say using insulin at that particular point seems to have favorable effects on the beta cell. So there is animal evidence, there is clinical evidence, they have everything. And that's the best we can do, and I don't think it's a big deal. We're talking about 4 weeks, come on. 4 weeks, they just buy one pen and use it and that's it, finished. If that is going to change, why not? And there's not going to be a big cost added, there's no hypoglycemia added, there's no weight gain added, there's nothing. No side effects, so why shouldn't we use it early? Why can't we be aggressive?
Sir, with your permission, I will say something that your father would say whenever he started insulin right at the beginning. As students, this was the example he would give to the patient. He would say, look, your wife is a good cook, I know, but right now she has got typhoid, she has got fever, and you have called 50 people home for dinner. She can't cook, she needs rest. If she rests, she will come back, and next occasion she will cook. So this time, you taking insulin is like taking food from outside or getting some help to your wife. When once she rests, she is going to bounce back and cook. And I used to be stunned because most patients with this example would agree to take insulin. And this was in 87, 88.
Excuse me, sir, again to Dr. Mohan. In between analogs and basal insulin and ordinary mixture insulins, Is there any criteria in choosing which insulin you use? It is not the cost, it is not the necessity. What makes to choose analog insulin instead of best insulin?
Yeah. I can share with you something in confidence. I was part of, I hope the pharma people are not here. I was actually chairman of the IDF task force on insulins for the world, and we had to write this, and we had the former IDF president, the ADA president, and many other people from the world to write this. And the reason we were prompted to write this was because in Africa, it came to our attention that in Africa there are some countries who buy the costliest insulin, and therefore only 10% of their patients in that country can get insulin. Many die because there's no insulin available. Insulin is given by the government. Government buys the costliest insulin, and therefore their budget is limited. So 90% of patients are not getting insulin, and people die. Okay? So we had to ask this question: how much improvement is an analog insulin giving over the regular insulin for survival? Okay, does it make a big difference? If you give analog, they won't get complications. If you don't give analog, they will get complications. There is no data. There is absolutely no data. It doesn't mean that the analogs are not a step forward. A Mercedes-Benz is definitely better than a nano car. There is no doubt. We are not arguing about that. The question we are asking, can you still go in the nano car? That's what we are asking. We are not saying Mercedes is not good. Mercedes, Rolls-Royce is Rolls-Royce. Can you still go in a nano car and still get to a place if you cannot afford the Rolls-Royce? And the answer is yes. You can still go. It's still a good car. You can still use it. So what we have written as a position statement, which will now get published soon, is that governments should first ensure that insulin is available for everyone. It doesn't matter which insulin. If there's a very rich, Qatar government which can afford to give analogs to everyone, so be it. Give it. Okay, nobody is saying no. But if you cannot, even Rwanda or in Gambia or some place like that, Sudan, where there is no insulin even, there you try to buy analog insulin. What we are saying is the IDF recommends that first you give the insulin, human insulin, which is the cheapest insulin, to everyone. Over and beyond that, you keep the other insulins available. If there is a particular individual who is allergic to this insulin or cannot use it and needs that insulin, then you use it. Or if there's a proven point in a particular individual that that particular analog is going to be useful, use it. So we are not saying don't use analogs. What we are saying is make insulin available to everyone. So in poor countries, I think we have to make sure that insulin is available. There are benefits. I mean, postprandial hypoglycemia or earlier thing, you don't have to wait for 30 minutes. The late hypoglycemia is less, the peak is better. All these things are there. We're not saying it's not better. If you take a Rolls Royce or a Mercedes-Benz, you can sit, the chair will go, the seat will go this way, that way, you can lie back, you can do lots of things you can do. It's fantastic. Nobody is saying that, but you're paying a price for it. Okay, and those who cannot afford it, suppose you say only Mercedes everybody should buy, that's not true, isn't it? But at the same time, you cannot say nobody should buy Mercedes. They want to buy that, they can buy that. They want to buy this, they can buy this. Everything should be available in a country so that insulin is available.
Last question.
I am Dr. Subramaniam, orthopedic surgeon.
After listening to bariatric surgery for and against, I am afraid we will be carried with the words. In future, all the 60 million people in India or 330 million people in the world, should they undergo bariatric surgery at the beginning? Or we should close 62% of patients are under remission, we should close, all of us to close our diabetic clinic and go. That should not be a message to be carried out. As a senior physician, I would like to tell the researchers, keep that in mind. But as if you are propagating that, I am very much afraid. I'm sorry to state this.
The question is to Dr. Mohan.
I'll also respond to that.
Have you come across these complications of pancreatitis and UTI in gliptins?
I have seen a couple of cases of pancreatitis with gliptins. Luckily, I have not seen pancreatic cancer so far. This is a subject of great debate now because there have been big reports of pancreatitis with all the gliptins virtually. But the good news is that the NIH convened a big meeting on this because a Peter Butler article published in Diabetes Care which scared the hell out of me because they showed tumors, pancreatic cancer tumors in those who have received gliptins. So there was the big shock for the whole world when all this came. But on 23rd, 24th of June this year, the NIH actually convened a big meeting. It was a 2 to 3 day meeting where they looked at the entire data in the world And what they have said is that the data is not convincing now to say that somebody will definitely get pancreatitis. FDA has not given a warning on pancreatitis or pancreatic cancer, but the meeting concluded by saying that we have to keep watching because some signs, some signals have started coming. So the next 2-3 years is very critical to follow up these large series of cases and to see whether there is any real fear. So we cannot say no. At the same time, the evidence is not there now to say yes, there is pancreatitis and therefore you should not use these drugs. The evidence seems to be strongly in favor of continuing the use of these drugs. But you should be careful. If somebody has had pancreatitis earlier, if he is alcoholic, has gallstone disease, other risk factors for pancreatitis, better to avoid it in such individuals.
What about UTI?
UTI is more with the SGLT2 inhibitors rather than with DPP4 inhibitors. Sir, I'd like to just respond to my teacher, Dr. Sundaram's thing about bariatric surgery. Bariatric surgery is not a treatment for all diabetic patients. We're not talking about 62 million people in India doing bariatric surgery. We are talking about a person who's 140 kilograms in weight, who's breathless, who's not able to walk, whose sugars are not controlled with 3 times, 4 times insulin, taking 150 units per day. The more the insulin he takes, more he's going to put on weight, already developing sleep apnea, developed hypertension, his heart is beginning to enlarge, who may not live for 2 years if you don't do bariatric surgery. It's a last resort. So as a last resort, when somebody is going to die and you don't have that, you can take that little risk of this 1 in 200 or 300 people even dying due to bariatric surgery, because the rest of them anyway would have died if you don't do that. In such individuals, if you're able to get, in those extreme cases, if you're able to get 62% remission, then I think it is worthwhile. The Brazilian study is very interesting because they did it in normal weight people. But I don't think that has been replicated. There's only one center in Hyderabad which has done it, which claims it. All the other centers which are done in India have not reproduced it, and the US has not accepted it. So using it in normal weight people for curing diabetes is not been recommended by IDF, ADA or anyone. But you'll see that IDF, ADA, all the organizations said when the BMI is more than 35, if you have comorbidities, if they don't respond to anything else, try bariatric surgery as a last resort. So we are not saying every diabetic patient have bariatric surgery. It's certainly not true.
Now the message is clear.
Yes, sir.
We thank all the speakers for their excellent speeches and the good interaction by the audience. Now I give the mic to organizers.
There's a housekeeping announcement. After the lunch, people have to go to these respective halls.